Obesity is a disease and not a lifestyle disorder. We are the thin fat Indians. So even if we may not look obese, we may have a high body fat percentage, and then our lipids and triglycerides, cholesterols, they will be on a higher. So you have GIP, GLP, you have other Monjaro, which will be available next year. We have the injectable GLP-1 analogs, which will be available next year sometime. So they are good drugs. The clinical trials have shown very good results. Starting from 15 kgs to 25 kgs of weight loss. Suction is like it's a cosmetic procedure. It is external procedure. It has its own side effect. It is mainly done for cosmetic purposes. In no way it is going to change the metabolism of that person.
Hello, thank you for tuning in. If you want to come back to this video later, just tap on the like button. It will save it to your like videos so it's easier to find. And don't forget to hit on the bell icon to get notified whenever we drop new content. Stay curious, keep learning, and see you on the inside.
Good evening, everybody, and today's topic is obesity management beyond bariatric surgery, the long-term care and nutrition. So, I'm a bariatric physician. I work 24/7 in a bariatric surgery unit last 20 years, and that is how I get to see all pre or post-op patients of surgery as well as those who come in for medical weight loss. So, why is it important for to know the post-operative care of a bariatric patient? It is because these bariatric surgery procedures, they bring about anatomical changes in the GI tract, and these gives rise to various physiological changes. So procedure wise, the anatomical change can be in the stomach, and sometimes even in the intestine, or anastomosis with the intestine. And so the physiological change will be the change in the digestion and absorption of the food according to the change in acid secretion, the availability of various hormones for digestion, the contact time of the food with the enzymes, and also the space, which is total space remaining for absorption of nutrients from the food. So that contact time is also, and the contact length is also important. So the digestion as well as the absorption of protein, carbohydrate, fat, vitamins, minerals, trace elements, everything is affected. Now, the National Institute of Health states that after bariatric surgery, the post-operative care, the nutritional counseling, and surveillance should continue for an infinitely long period. That the change should be permanent. So we all know that obesity is associated with many comorbidities from head to toe, and which give rise to a very poor quality of life. So, for example, the migraine, depression, the benign intracranial hypertension, the obstructive sleep apnea, the obesity hypoventilation syndrome, dyslipidemia, cardiovascular disease, the non-alcoholic fatty liver disease, hypertension, the metabolic syndrome, GRD, the type 2 diabetes, the PCOD infertility in females, the urinary stress incontinence, hypogonadism in males, degenerative joint disease, venous stasis disease, gout, etc. And we also know now that post-bariatric surgery, there is comorbidity reduction of many of these comorbidities. For example, there is improvement in the liver steatosis, there is resolution of inflammation, there is 20% resolution of fibrosis, about 80% patients may have resolution of the diabetes type 2. Then hypertension may resolve 50 to 90% of people. There is about 80% reduction in the cardiovascular risk. There is decrease in the venous stasis disease. There is improvement in the polycystic ovarian syndrome and infertility, and the fertility rate may increase after post bariatric surgery. So the quality of life improvement is seen in about 90 to 95% of patients, and there is about 89% reduction in the 5-year mortality. But what we may miss in the pre-op session is that the nutritional deficiencies which already exist in patients suffering from obesity, these we cannot miss, and we have to treat this before surgery, and we have to look out for various nutritional deficiencies post surgeries, and as far as possible we should be able to prevent these deficiencies from occurring. So that is the goal of post-operative care. So the preparation for the post-operative care should start in the pre-operative period with a detailed medical, surgical, family history, the weight loss related history, the number of attempts, the response of the body to these weight loss attempts. The dietitian has a main role in understanding the diet of the patient, the likes, the dislikes, the physical activity, status of the patient, and what is a lifestyle, whether there are any addictions like smoking, alcohol, etc. Detailed examination like the general examination, the systemic examination. In addition to that, we should have some anthropometric examination like the height, weight, BMI, the waist circumferences, etc. And like in our clinic, we have a body composition machine, so we should do a body composition, which is very helpful, and it is for the patients to understand the distribution of the fat and the muscle, and it is very easier to explain to the patients. In the laboratory test, of course, we will have tests for fitness for anesthesia. And again, the effects of obesity on the body should be studied. So 2D echo, venous Doppler of the lower limb, so USG abdomen, the pulmonary function test, the various hormonal tests like insulin, C-peptide for the diabetics, the thyroid function test, the FSH, LH, prolactin in females, serum testosterone, free testosterone in the hypogonadism males. Nutritional evaluation baseline, you should know the protein, B12, folic acid, vitamin D, and also the serum iron status. And then we should refer to various specialists if and when required. Coming to the next part, important part is the education of the patient as well as the caregivers. They have to understand that obesity is a disease and not a lifestyle disorder only. So they have to understand the procedures which are available, which will be ideal for their patient, and what will be the pre-operative preparation, the intraoperative journey, and the post-operative journey and care of the patient. So that is very important to educate the patient as well as the caregivers. So in the immediate post-op period, the care will be as like any other surgical patient, like close monitoring of all the vitals, the blood sugars, the blood pressure, the input output, the SpO2, especially in those with sleep apnea or obesity hyperventilation. The pain management is especially very important because our aim is that the patient should have early ambulation to prevent any type of deep vein thrombosis. So it is very important to take care of the pain. And on day one, after a few hours, we start with sips of clear liquids. Before discharge, the patient is explained what to expect in the next 2 to 3 months. So in the long term management, the first 3 months, the diet pattern, it starts with clear liquids on day one of the surgery, and then we go on to small feeds of solid food up to 2 to 3 months, depending on the procedure. During this time, the patient understands the hunger, the satiety, and as well as the portion size which is required for satiety. So we have to educate the patient and the relatives regarding the nutritional content of this small volume of liquids or solids that they are going to take in these first 3 months. The medicines, of course, whatever pre-existing illnesses are there, that days the patient should continue. We have to manage the antihypertensives and the anti-diabetic medications, because as we know, there is diabetic resolution. We do not want the patient to continue with the same medications and end up in some hypoglycemia or end up in hypotension. So that has to be monitored. So the patient who stay away, they can do it at their general practitioner, their family doctor level. It is important to take ursodeoxycholic acid to prevent formation of gallstones, because there's going to be substantial and rapid weight loss, and we know even any type of rapid or substantial weight loss can give rise to gallstones. So we should prevent that, because it will be additional complication for the patient. So this is continued in the dose of 150 to 300 milligram for 6 months at least. All the medications preferably in dispersible or syrup form, because if the patient needs to take a big capsule or tablet, they need to take a big bolus of water with that, and that may, if the stomach is already full, this may just end up in the esophagus and cause irritation and nausea, vomiting, and problems to the patient. Whatever nutritional supplements are required prophylactically to prevent deficiencies should be continued even in this period. The physical activity to increase slowly from walks of longer duration and a little bit speeding up. Yoga can be added, and some strengthening exercises can be added depending on the patient tolerance. In the long term, from 3 months onwards, follow up with the bariatric team should be encouraged, and it should be at the third, sixth, ninth, 12th month in the first year, at least twice a year in next 4 years, and at least once a year henceforth, where the team needs to follow the previously abnormal tests, the reports, repeat the nutritional test, monitor any pre-existing illnesses, and basically study the meal pattern of the patient, where you have to see that the patient eats small volume solid meals with plenty of liquids in between the meals, not with the solid meal. And this whatever food is, it has to be nutritionally correct. For example, there has to be some protein in each meal, and supplements should be advised, and they should be advised correctly. And if to encourage the patient to take the supplements, why we will see later. The patient should remain physically active, and like I said, you can add yoga, you can add muscle strengthening. Those who want to go to the gym, especially the young males, they are very enthusiastic about wanting to go back to the gym. They can go for swimming, zumba, dancing, whatever physical activity, whatever they like, and whatever they can do, and whatever they can add in their daily routine. If there is any change in the eating habits, or if there is increased hunger, if there is decreased satiety, if there is a weight loss plateau or some weight gain, then the patient should come to the bariatric unit at any time that they want, and they want to discuss. And it may happen that after 5 to 10 years, especially with restrictive procedures, or if the patient undergoes unfortunately some different kind of um, uh, event where there is weight gain, then the patient, we may have to consider the patient for revision, and therefore it is important for the patient to come. So as we know, there is improvement in and remission of many comorbidities. A word here about PCOS, infertility. It is known that fertility improves after bariatric surgery. So those who are keen on getting pregnant, they should avoid getting pregnant at least for 1 year, because the mother's body is still undergoing weight loss, and she needs some vitamins and proteins, and so she should be properly ready to conceive. And so we should advise them to avoid pregnancy at least a year, and we should guide them accordingly. So it is why is this nutritional management after bariatric procedure important, and how do bariatric procedure challenge the nutrition? Is it possible to maintain the RDA, that is the recommended daily allowance? Is it just enough, to follow a fixed protocol, give a type sheet to the patient, or should the dietary requirement made tailor made with frequent reviews? So let us see this, and whether we should target to be the calories, or proteins, carbs, fats, or vitamins and trace elements. Should we make use of supplements? Can dumping be prevented or treated without any reversal? Does diet play a role in reaching as well as maintaining the lost weight? And how will the newer procedures affect nutrition? And uh, so let's see what happens. The problem is that with the anatomical changes, what happens is there is volume restriction. So when the stomach size is made smaller, so this volume restriction therefore mechanical because of the small stomach, as well as because the fundus part of the stomach is removed. There is decrease in the hunger hormone, which is the ghrelin hormone, and therefore decrease of this gives a early satiety. So the patient is going to eat a small volume of food, and therefore the challenge is to maintain the nutrition in that small volume of food. There is decrease in the acid content of the stomach, as well as there is decrease in the intrinsic factor. So the digestion of protein, iron, B12, everything is affected. There is rapid stomach emptying time, and this has been studied by many units, with less churning of food particles with the acid. So if the food particles are complex food particles, then the acid does not get time to act on it. So there is also exclusion of the upper part of the intestine, the duodenum, the upper jejunum, and sometimes even the ileum. So no direct contact of the food for either digestion or for absorption. There is also less surface area for absorption of the nutrients in the malabsorptive procedures, where we will see in the diagrams that a very small part of the ileum is available for absorption of the digested food. So there is increase in the transit time in the intestine for the food. So there is a decreased time, again contact time, for digestion and absorption. There is a change in the gut microbes, even and microflora, even in the in any obesity patient that we see, and this is also true post-op. There is also variation in the length of intestines. This also will absorb the affect the digestion as well as the absorption. There are many other factors like inadequate supplementation, compliance of patients with the diet, with the supplements, the affordability, the willingness of the patients to take these supplements, and these are something that we have to take care of. This is an important diagram. It shows the absorption, the digestion, absorption of the nutrients from the of the GI tract. And as you can see, in the mouth you have the salivary amylase, in the stomach you have the gastric juice, and if you note, alcohol is the only substance which is being absorbed from the stomach. So this is an important point to remember. And then you can see that in the duodenum and the upper jejunum, maximum of the micronutrients are absorbed with the help of the pancreatic juice and the bile acids. And so there is exclusion or lack of direct contact or less time of exposure in various malabsorptive procedure, which we should understand. For example, now if we look at the protein digestion, in the protein digestion starts in the stomach. The gastric mucosal cells, they secrete the gastrin, which secretes the gastric juice, and that has the hydrochloric acid as well as the pepsinogen. Now, what happens is the hydrochloric acid denatures these proteins, unfolding their 3D structure to reveal the polypeptides. And it also activates the pepsinogen to pepsin. Now, this pepsin enzyme then breaks the polypeptides into smaller polypeptides, and this all enters into the small intestine, where in addition the trypsin, chymotrypsin, and other proteases, they continue with the enzymatic digestion of these tripeptides and dipeptides to amino acids, which are then absorbed into the intestinal enterocytes. So in the duodenum, the breakdown of complex molecules of the protein takes place, and in the ileum there is complete absorption of the protein. So wherever the stomach size is decreased, the duodenum and jejunum is excluded, especially in these malabsorptive procedures or the bypass procedures. The protein digestion as well as the absorption, both are affected, and that's why the need for protein supplementation. Coming to the carbohydrates, the salivary amylase breaks down the starches to maltose, and then in the intestine, the polysaccharides are broken down into disaccharides like maltose, sucrose, and lactose, and these are broken down by the respective maltase, sucrase, lactase to monosaccharides. So glucose plus fructose, and glucose plus galactose. Important to note is that in case of carbohydrates, the absorption of carbohydrates occurs throughout the small intestine. So simple carbohydrates, if taken like various milkshakes or sugary drinks, so they are easily, readily absorbed even after bariatric procedures. And this can also give rise to dumping syndrome, and it can give rise to weight gain. So the ingestion of carbohydrates, and especially simple carbohydrates, has to be less. And what you have to include in the diet is more of complex carbohydrates and fibers. Coming to the fat digestion, fat is actually exists in the form of triacylglycerol. In the mouth, with the help of the lingual lipase, the digestion of the fat begins. And in the stomach, you have the gastric lipase, which is secreted from the chief cells of the fundus, which breaks down this TAG into diglycerides and fatty acids. And what is important to note is that again, in the small intestine, you have the lipase and colipase for further breakdown. But here is the role of the enterohepatic circulation. So these fatty acids, they combine with the bile salts, which are released from the gallbladder in response to cholecystokinin. This forms micelles that facilitate lipid transportation, that is fat absorption across the intestinal membrane. So whenever there is the resection of fundus, so the gastric lipase is not available, there is exclusion of the upper intestines in the malabsorptive procedure. So this affects the fat digestion as well as absorption, and it also interrupts the enterohepatic circulation. So similarly, the absorption of the fat soluble vitamins is also affected. So whenever there is lipid malabsorption, where there is steatorrhea, where there is a loss of fat in the stools, it results in poor uptake of all the fat soluble vitamins. And so the solution for this has to be dry, water miscible forms of fat soluble vitamins in the multivitamin capsule that will enhance the absorption, because they do not need to be taken with fat. So that is something to remember. So the enterohepatic circulation is partly shortened or interrupted after a bypass procedure, but this is a Good thing that this decreases the fat absorption, formation of cholesterol. Coming to the B complex vitamins, thiamine, cyanocobalamin, biotin, pyridoxine, niacin, riboflavin, folic acid. So these are important, and these vitamins are actually coenzymes or cofactors, and they help to transfer atoms or groups of atoms in the metabolism of carbohydrate, proteins, as well as fats. Now, looking at B1 vitamin, the importance post-bariatric surgery is that though there are many depots of the B1 vitamin in the body, what happens is if there is recurrent vomiting post-surgery, it may be drug-induced, it may be because of wrong eating, it can be because of a twisted sleeve, or for whatever reason, or some hernia, internal hernia, at any stage. If there is recurrent vomiting, the thiamine stores can deplete rapidly, and this has to be remembered. Secondly, B1 to act in its active form requires magnesium, and magnesium is easily available and done even in the laboratory tests. So it is important to monitor the magnesium levels. B12 I should mention, because B12 also called as cobalamin. So when it enters the stomach, it is attached to the intrinsic factor which is secreted by the parietal cells of the fundus and body of the stomach. So what happens is this B12 intrinsic factor complex, and this travels all the way down the intestine to the ileum, where the whole complex is absorbed into the intestinal epithelial cells, and then the intrinsic factor is released, and the B12 is absorbed by another protein. So there is no actual digestion, but B12 requires the intrinsic factor. So even in restrictive procedure like a sleeve gastrectomy or anything which decreases the stomach size, B12 absorption is going to be affected. But what is good about B12 is that it can be passively absorbed. So even if you give oral B12, some part of it absorbed all over in the intestines. And the solution to this is nowadays, there are available some buccal sprays, intranasal sprays, sublingual formulations, intramuscular, or even IV injections. So, B12 the deficiencies can be prevented, and it can be given in any form. Coming to vitamin D and calcium, it is important to remember that the gastric acid solubilizes the calcium, and then it is in the intestine, it is absorbed. And active vitamin D3 is important for absorption of calcium. So, what happens post surgery? Because the acid is less, we should give a acidified version of calcium. So the calcium carbonate which we rampantly use is actually not absorbed in a post-bariatric patient. So we have to give the acidified form like a calcium citrate, which is now easily available. It can be given as 1200 milligram during the day. And if calcium lysinate chelate is available, then it should be given because the bioavailability of this formulation is much more than the other calcium which are available. Coming to the trace elements, they are dietary elements that are needed in very minute quantities for the proper growth, development, and physiology of that organism. And they're required in just about less than zero point 0.1 gram per liter. There are about 14 elements which are essential for human beings. Not all are essential, and the two main reasons for the measurement in a clinical nutritional setting is to determine one deficiency, and second would be any toxicity. So they're capable of causing toxicities. So they're divided into essential, probably essential, and toxic, and we will concentrate more on the essential ones: iodine, iron, zinc, selenium, copper, cobalt, chromium, etc. So, about their absorption, the exact site of absorption is not actually well known or well studied, but mainly the duodenum and upper jejunum. One thing normally good is that their absorption is self-regulated, but post bariatric surgery we do not know how much or how their absorption is affected. They may have an antagonist or agonist actions among themselves, like iron will decrease the absorption of zinc, or selenium will increase the absorption of iodine. So we have to be careful when we are subscribing then the the trace elements pill of any sort. The form of element is also important, whether it's ferrous or ferrite, or whether it is zinc, like zinc citrate, acetate, picolate are better absorbed, which means post surgery acidified forms of these trace elements are recommended. So if time permits, we can just see The functions of these trace elements, manganese, as we know, is supports the production of sex hormones, regulations of blood sugar, and absorption of calcium, also for breakdown of dietary fats and carbohydrates. The copper is required to produce enzymes which felicitate the production of various neurotransmitters like epinephrine, norepinephrine, histamine, serotonin, and dopamine. Fluoride is important to prevent to decay iodine to produce the two important thyroid hormones. Chromium enhances the action of insulin, a hormone produced by the pancreas, as we know. So, whenever there is a sweet craving after bariatric surgery, do think of chromium. So, do the chromium levels. I know they are expensive, but we can do the chromium levels and give chromium supplements, and it helps. Selenium combines with proteins in the body to form selenoproteins, which act as antioxidants. So the next thing, just a word about iron. It is necessary to produce the proteins hemoglobin, which we find in the red blood cells, as well as the myoglobin found in the muscle cells. But it is also important for brain development, immune function, temperature regulation, etc. The zinc promotes enzyme activity, supports immune function, antioxidant, aids in wound healing, DNA synthesis, as well as cell division. So, it is an important element to think about. It has a role in increasing testosterone and semen volume in males. So, it is important for those with hypogonadism. The word about iron is that iron exists in the oxidized or the ferric form, that is Fe3 state. Now, to be absorbed, it must be in the ferrous, that is a reduced form. It should be Fe2 plus, or it should be bound by a protein such as heme. Now, what happens in the stomach is the gastric acid or presence of ascorbic acid, that is vitamin C, that can promote the reduction and the solubilization of the dietary ferric iron and improve absorption. But since post-bariatric gastric acid is less, you should give vitamin C with the iron for better absorption. Secondly, duodenum and upper jejunum, the intestinal mucosal cells usually absorb the iron, and in malabsorptive procedures, this will not happen, and therefore you should give reduced forms of iron, that is the ferrous form of iron. There are actually many papers which talk about trace element deficiencies after bariatric surgery, and I'm not going to discuss all of them now, but you can always look up the literature. So, different elements can cause the same presentation like anemia. Now, anemia can be because of iron deficiency, it can be because of copper, zinc, selenium, hair loss, especially females. So, iron deficiency, copper deficiency, zinc deficiency, which normally we don't think of, we only think of protein and biotin. Neuropathy, myelopathy can be copper, selenium, and also that B12 deficiencies, especially in diabetics and those on metformin, etc. Neuromuscular cardiomyopathy in selenium deficiency, erectile dysfunction, hypogonadism in males, think of zinc deficiencies, sweet craving, think of chromium. So, when there is deficiency of one element, there is a possibility of deficiency of other elements. So, you can give them, if you cannot measure them, at least give them give a proper just like a multivitamin capsule. You should give something which contains these multiple trace elements. There is one paper which said that the variable addition of zinc and iron is a good predictor of hair loss. Especially, they have done this in females after sleeve gastrectomy. So, patients with addition levels below 115 have a fourfold more susceptible. They are fourfold more susceptible to present with hair loss, and therefore, in such cases, timely zinc supplements will stop or prevent the hair loss in addition to iron. So, applying all this knowledge to these various bariatric procedures now. So, this is a restrictive procedure. It is called a sleeve gastrectomy. Now, the anatomical change here is that there is a formation of a stomach tube, and the remaining stomach, the resected stomach, is removed from the body. Now, here the pylorus is intact, and there is no anastomosis, there is no duodenal exclusion. But what will be the challenge? There will be volume restriction, decreased protein intake, early satiety, less acid, less intrinsic factors, so protein, iron, B12, all digestion will be affected, and also a higher motility, so less time for the acid and the food contents to mix. So, easily digestible soft food should be taken by the patient. Gastric bypass, which is a gold standard, here the anatomical change, as you know, is a small stomach pouch, and the excluded stomach, the duodenum, the upper jejunum, which is bypassed, is still inside the body, and there is anastomosis at the lower end of the jejunum, and anastomosis of the jejunum with the stomach. So again, same problem: volume restriction, less acid, less intrinsic factor, duodenal exclusion. Mixing of the food is at the lower intestine, and after the mixing of the food is the remaining part of the ileum where the nutrients will be absorbed. But this is a longer portion than compared to other malabsorptive procedures. Of course, here the fat soluble vitamin absorption will also be absorbed, and therefore oral supplementation should be considered. Other malabsorptive procedures, these are severely malabsorptive. The bilipenetrant diversion, which was one of the first procedures to start, it had a big stomach and a very small absorption place, just about 50 centimeters of ileum. This was modified to a BPDDS, where the stomach is now in a longer pouch, and there is a little bit longer common limb for to prevent. This is to prevent dumping as well as to prevent severe protein malnutrition. So there is another procedure called as mini gastric bypass. So if you compare it to the Roux-en-Y gastric bypass, you can see the stomach is a long tube and not a small pouch, and you can see that this is the remnant stomach with this intestine, and this is looped and it is connected to the lower end of this stomach tube. And so there is only one anastomosis, while in a gastric bypass you have two anastomosis, and that's what is also called as one anastomosis gastric bypass. So to prevent or to minimize the malabsorption or the nutrient deficiency challenges that we have with other procedures, some newer procedures are being they are in innovation. Like for example, this is the loop transit bipartition here, where you have the stomach tube. There is a small anastomosis here with some part of the intestine, the jejunum probably, and this is in continuation. So what happens is part of the food can pass through this normal intestinal passage and help mix with the normal juices and be absorbed, and part of it can pass through these anastomosis. So long-term results are yet to be published, but what happens here is hopefully that the challenge of micro and macronutrients will be less. Dietary supplements will work better, but of course the effect of the sleeve, as in sleeve gastrectomy, the volume restriction and all, will probably continue, and patient will have good weight loss but minimum nutritional deficiency. So these procedures are becoming quite popular. Intestinal adaptation in malabsorption is a compensatory mechanism that follows an abrupt decrease in the mucosal surface area. It has been well studied in short bowel patients who required the bowel resection. It starts post-operatively and it goes on till 3 years, and but this is mainly for the macronutrients. So this may be one of the reasons why a patient may have weight regain. So you have to watch out for this stage and help the patient. So nutritional care after any weight loss, the newer weight loss drugs which are going to bombard the market in next 1 to 1.5 years. So these can induce lots of substantial weight loss by literally almost the same action, like volume restriction, calorie restriction, delayed gastric emptying. The patient additionally will be on PPIs or the H2 blockers or various antacids to overcome the GI side effects. So what will happen is long-term use of these medications may induce similar micro and micro deficiencies, just like a sleeve gastrectomy. So as clinicians, we should be on a watch and see that the patients do not suffer, and the same principle like a sleeve gastrectomy will be applicable to the newer drugs. Well, okay, so why supplement? The pouch volume of a bariatric procedure is just about 50 to 120 cc max. So 150 grams of food may fit into that. It is not possible to meet the RDA. So trying to achieve the RDA by diet alone is like a pipe dream. And therefore, for long-term weight maintenance, supplements should be used patient-wise, procedure-wise. Attempting to increase a volume of food for achieving the RDA. So never say to the patient, okay, you eat more, so that you will put on a little bit 2 3 4 kgs and you will look nice and this and that. We should not encourage the patient to eat more or increase of volume, because it may dilate the pouch and it can be the factor responsible for weight regain. Hence, a relatively healthier composition, lower in calorie with macro and micronutrient supplements, forms an ideal protocol for nutrition after bariatric surgery. And the exception may be the newer bariatric procedure like transit bipartition and the sleeve jejunal bypasses and the sleeveless procedures, which permit transit of food through the normal passage of intestine and partly through the bypass, the diagram that I just showed you. Just important to remember that intravenous dose of a drug has 100% bioavailability. So make use of IV, like vitamins and all, wherever required. The lessons that we have learned in this bariatric care of last 2 decades is the preoperative assessment, evaluation, treatment of baseline nutritional deficiency, educating the patient of the same or the same is very important. In the postoperative period, regular follow-up, evaluation of calorie and nutritional intake, compliance with diet advice, compliance with the medicine advice, the affordability of the patient, the viability of the things that we use. We should make use of supplements whenever possible, but again, we have to think about the affordability of the patients. We have to make use of intravenous and intramuscular drugs whenever needed, and especially when the patient is not very compliant, the patient is not taking the supplements, and we don't want the patient to end up in a malnutrition state. So the nutritional care comprises of nutritional education, healthier options combined with bariatric specific supplements in bariatric doses. Supplements vary based on type of procedures. Prevention of nutrient deficiencies and maintaining the bariatric volume are key to long-term maintenance of the lost weight as well as a good quality of life. And as clinicians, it is our duty to give a good quality of life, not just a good weight loss. So helping the patient's weight loss journey is a team effort. So along with the bariatric surgeon, we need physicians, nutritionists, psychologists, as well as bariatric coordinators. And therefore, a transdisciplinary team is required, and proper selection and proper training of the team is also very important. So, just one example how the quality of life is important. A young adolescent girl with PCOS and weight gain and insulin resistance, pre-diabetes. So she underwent a procedure, she lost weight, she got married, she got 2 kids, she did put on weight. But after that, we have added, because her first procedure was a restrictive procedure, we now have added a malabsorptive element to that, and she is back to how she was. In fact, she's lost more weight, she is happy, she's able to take care of her kids, and she can take care of herself, because it's now almost a period of 10 15 years that she's been our patient, and she's in touch with us though she is abroad. So thank you very much. And I forgot to mention that whatever guidelines, if somebody is interested in knowing the nutritional guidelines, they are available on the ASMBS website. There are various articles by the Integrated Health also, or also on another association which is called as IFSO. And there are some articles by Indian groups also. So I have not discussed the doses because they are different, and they are available on the internet, and I just wanted to explain the logic behind the post-operative care and the nutritional care. Thank you very much.
We will now get started with the Q&A. So I'm going to be taking one of the earlier questions that we had. Dr. Kulkarni asks, apart from dieting and exercise, what other precautions can be taken to avoid obesity?
To avoid obesity. Actually, obesity is multifactorial. Many cases, many patients, we have seen that there is a genetic predisposition. So if your family members are obese, then you can make an attempt by following a good diet, a good physical activity, and whatever illnesses are there in the family, like if there is a family history of diabetes especially, then you have to be on the alert to see that you do not become a diabetic, that you do not have pre-diabetes, and you should take good care of yourself. You should nutritionally also take good care of yourself. They say that vitamin D is associated with obesity, or B complex can give rise to the various problems. So diet and physical activity remain the cornerstone, but a genetic predisposition, avoid junk food, avoid other behavioral problems like alcohol, smoking. If you can avoid these things, and all the endocrine disruptors which are present in our junk food and all, so you can prevent obesity and take good care of yourself.
So Dr. Abhishek says, hello ma'am, does hyperlipidemia and obesity have a relationship in between?
I don't know what comes first, whether the obesity or the hyperlipidemia, but hyperlipidemia is seen in majority of the obesity patient. But like in our Indian phenotype, we say that we are the thin fat Indians. So even if we may not look obese, we may have a high body fat percentage, and then our lipids and triglycerides, cholesterols, they will be on a higher side. So like I said, I don't know what comes first, but yes, it is hyperlipidemia is seen in many of the obese and many of the non-obese patients also. So what is important is also to do a body composition. Along with doing the lipids, it is important to do a body composition and find out the body fat percentage also.
So Dr. Kulkarni asks, what is your opinion on herbal shakes therapy for controlling obesity?
Actually, I have no experience about that, but patients do come to us. See, no, other than surgery, I have not seen any other shakes or any other treatment giving a long term weight loss. And since we do not know the herbal shakes constituents, I do not know. But there are protein powders which are available, which do not have sugars, which we also use for pre-operative weight loss, or on a weight loss plateau when the patients have. But because I have no knowledge about the herbal shakes and their constituents, I'm not the ideal person to comment on that.
So next question says, management of relapse post-bariatric and gastric sleeve surgery.
So gastric sleeve surgery is basically a restrictive procedure, like we said, where only the stomach the fundus and the greater curvature is slightly removed. So there is decrease in the ghrelin hormones, and so like I said, there is a mechanical decrease in the amount of food that the patient can take. Now, what happens over time is, if after some time patients think, okay, now I can eat one fulka, so why don't I try one and a half? Now I'm eating only fulka, why don't I try some rice also with the fulka? Why don't I, I've just eaten something at home, but my friend comes with something, and I cannot say no, I cannot say that I'm going to sleep, and I try to eat. So whenever little the patient tries to eat more, the patient can end up in dilating the pouch of the sleeve gastrectomy. So the management would be, we do endoscopy, we do barium, we try to see how much the sleeve is dilated, and if required, we can just it's like trimming a sleeve of the a dress. Like if it becomes very loose, you can trim the sleeve, and or if required, if the patient has additional metabolic problems like infertility, or if there is diabetes, you may add a malabsorptive element and give weight loss to the patient. But it is known that in a gastric sleeve, after a few years, gastric pouch dilatation and weight gain can happen. We can also make use of the newer drugs if there is not too much of a pouch dilatation. So that is a newer addition to management.
So next, Dr. Pankaj asks, can you compare newer anti-obesity drugs like Ozempic with lifestyle interventions, and which is better?
Okay, so you're talking about Ozempic with lifestyle intervention. See, lifestyle interventions remain the cornerstone of any weight loss. But Ozempic is going to help that patient to lose more weight by decreasing their the appetite, the giving earlier satiety, decrease. So the decrease in the volume of food that they are going to eat. So it is going to help. Lifestyle intervention alone may not work in some cases. So this is definitely going to help, no doubt. No, it cannot be. You cannot say better. It is better with the added drugs. That's what it seems to be now. Next.
Dr. Rao says many obese clients insist that they are putting on weight despite reducing the food intake, and does that actually happen?
Is this related to bariatric surgery or in general? What did he mean? Because
Sir, if you could elaborate. Yeah.
yeah. So because like I said, if there is a weight regain after few years of a procedure, then there can be multiple reasons. Like one of them, like I said, there is intestinal adaptation. Only if it is a restrictive procedure, then a patient will put on weight in an earlier stage than a malabsorptive procedure. And usually, it is not just restricting the food intake; it is the type of food intake also matters. How the volume, the number of times that the person eats, what is in that food that the person is eating, and what is the additional liquids or alcohol or other sugary drinks or whatever that the person is taking along with the food, that also matters. So only restricting food intake does not help. And what happens is the ghrelin, if you're talking about medical weight loss, the ghrelin level in the body starts to rise because the body feels okay, this the brain feels that this body is starving, and so it secretes more, it makes the stomach secrete more ghrelin and the person feels more hungry. So even if they try voluntarily to restrict the food, they may not be able to do that, and that will make them more hungry. So that is with the medical weight loss.
Dr. Parvin says, great, unique session, very practical and enlightening. Dr. Rashmini sir says, excellent work on bariatric medicine as a whole, conceptual academic discussion, and thank you for the updates.
Thank you so much.
Taking the next question from Dr. Patel. Is there any lifetime B12 injection?
No, not that I know of. What do you mean? Something with a longer? See, it is a water soluble injection, so it is not just going to stay in the body forever. I don't know if there is any depot type coming up, but lifetime, no.
Next, Dr. Swami says, how can the collaborate team be built to reduce obesity post-op?
Any quality can. What is that? Any quality?
Any quality can make, I think, sir is asking about quality improvement.
And I don't know the full form of QIP, but what we are talking about is a proper comprehensive team for the post-op, and that is the ideal most thing to have. So no bariatric surgeon should work alone, because the patient needs lifelong follow-up, and starting from the pre-operative period, there is a big role of especially the nutritionists and the bariatric coordinators and the psychologists in the team. So they have to work together as a team, and that's why it's called as a transdisciplinary team, where there are no specific duties. Only everybody has to work together, and then only they can help the patient to not gain weight after any procedure. Like even if a patient has any stressful event in his life, any fractures, any psychological stress, if the team is there to help that patient, we can prevent that patient from wrong eating or emotional eating or doing any sort of wrong things. So if that is what I understand, yes, we need a nice team to help the bariatric patient.
Next question from Dr. Kumar. Is the size of the stomach of an obese patient bigger than normal? If yes, what is the reason?
No, not actually. The stomach is an elastic organ, and so in volumeters, you will find that the stomach size is bigger, but there is no specific measurement for that. And the size of the stomach does not correlate with the obesity of the patient. That is another thing that we should remember. I think so it is more about the length of the intestine, which is responsible for absorption of fat, which will make the patient obese compared to the size of the stomach. So size of stomach and does not correlate with the obesity of the patient. And in these procedures, like in a sleeve gastrectomy, almost 40 to 50% of the stomach is removed. In spite of that, patient can end up dilating the pouch and putting on weight. I hope that.
So, ma'am, there are some similar questions on protein shake and supplements. So, I'm addressing it together. So, are there any protein shakes or supplement that can reduce weight, and what are the possible side effects? Because currently there are many available in the market.
Right. So whenever we are looking for a protein supplement, so what we are doing on a daily basis, so we are talking about meal replacers. We are not just using the only protein supplements. We are using meal replacers. So the meal replacers are used instead of one meal, and they are taken with either water or diluted milk. And these are so they have everything. They have protein, vitamins, everything, like how a balanced meal would be, and they do not have sugar. So you have to, when you're giving something to a patient, you have to look out for these supplements, which they have to see what is the protein content, what are the vitamins which are there, and see that there is no sugar in it, and if it can be used as a meal replacer, not just a protein shake to be taken anytime. When it is used as a meal replacer, it does help in the weight loss, because that is what we do in the pre-operative period. We use these meal replacers once or twice a day. With then, whenever the patient feels hungry, then the patient has just some salad or a little bit of fruit, and that is how we bring about weight loss in the pre-operative period. So that is what we should search for.
Next, Dr. Majumdar asks, how effective is metformin to cut down excess weight? And if yes, then what is the dose?
Metformin is not used as a weight loss medication, but in some patients, it does bring about some little bit of weight loss. Hardly, like, nothing very substantial, or to let it know as a weight loss drug. So metformin is usually used for diabetics or pre-diabetics, even for PCOS patients with the insulin resistance. It is used from the dosage of 250 milligram per day, and its maximum dose is 2 grams, but not for weight loss.
Next, from Dr. Abhishek, ma'am, you mentioned that genetic predisposition is the major factor for obesity. Can you please suggest any genetic tests that are available for obesity, and please address the latest FDA-approved anti-obesity drugs?
So we are not into the genetic testing unless it is the syndromes that we see in children. So I don't know much about the genetics test, but yes, some are available. Whether they are used or not, I don't know. But yes, for in research background, they are used. And the second was about the FDA approved anti-obesity drugs. So the latest drugs, the what we are talking about last one whole year is about the GLP-1 receptor agonist, and they are soon going to be available. We are taking the oral is available in India since last 1 year, and they are in the college ribelsis in a dose of 3 milligram, 7 milligram, 14 milligram. So you start with the minimum dose and you go on increasing every the 3 to 4 weeks. Still the patient feels the effect. It decreases the appetite, and that is how it brings about the calorie restriction, and it brings about good weight loss. There are more drugs coming in. You have GIP, GLP. You have other. What's that name? Monjaro, which will be available next year. We have the injectable GLP-1 analogs, which will be available next year sometime. So they are good drugs. The clinical trials have shown very good results. Starting from 15 kgs to 25 kgs of weight loss. So that's why I mentioned that slide where I said they can. Because they work mainly with GLP, GIP based action. So the action is similar to what happens in a sleeve gastrectomy or in a gastric bypass, and that's why I mentioned that they can end up giving lots of nutritional deficiencies if we do not keep a watch on the nutrition status of the patient. So they have to be closely monitored.
So, ma'am, there are still some questions coming in. Is it okay if we take a few more, ma'am?
Yeah, no problem.
Next, Dr. Sabia asks, ma'am, the role of liposuction and abdominal obesity.
So liposuction is like it's a cosmetic procedure. It is external procedure. It has its own side effect. It is mainly done for for cosmetic purposes. In no way it is going to change the metabolism of that person. It can have a side effect like bleeding in the area where the liposuction is done, and so it cannot be used as a weight loss procedure. But if somebody has, at the end of a weight loss, if there is a pocket of fat somewhere in the abdomen, which is, properly seen, and then if you make use of liposuction, yes, can be, it can be used, but not as a procedure for weight loss.
Next, Dr. Sheikh says, status of vitamin B12 after sleeve gastrectomy or bariatric surgery in the long run.
Well, because it is a water soluble vitamin, it is not going to have depots in the body, and the status of the sleeve gastrectomy, that there is going to be a decreased intrinsic factor, whether it is sleeve gastrectomy with any other bariatric surgery, because the fundic part of the stomach and major part of the stomach is either removed or it is resected away. So this problem with vitamin B12 is going to remain, and therefore the patient will have to take this in the long run. And we have patients now about 15 years, 20 years of sleep, and in between they have to take, and they prefer to take the sorry. So they prefer to take the injectables, mainly IM or IV. So it has to be something which is to be given lifelong, irrespective of whether the patient is a vegetarian or a non-vegetarian.
Next, Dr. Majumdar asks, who is an ideal candidate for bariatric surgery?
So there are many actually indications for bariatric surgery. One of them is a BMI, because the original guidelines are based on BMI. So somebody like according to the international guidelines, so somebody with a BMI of more than 35, no comorbidities, is still a candidate for bariatric surgery. For from Asian point of view, because we are the thin fat Indians, the guidelines for us are less. So anybody who is more than 27 BMI, 30 BMI, but is a uncontrolled diabetic in spite of medications and long-term taking care of himself or herself, then such a candidate can be considered for. These are called as metabolic surgeries, not just bariatric surgery. They are called as metabolic and bariatric surgeries for any metabolism where the patient is suffering unnecessary. So do not um, catch the patient in guidelines and legal problems. So insurance people do follow this, that the BMI itna chahiye, and so but as clinicians we have to decide when to subject a patient to a bariatric surgery. So one is BMI, very high central obesity, very short females with very big abdominal obesity, very bad diabetes, hypertension, PCOD or infertility, young females, hypogonadism in young males. So there are many indications. Sleep apnea, again, very important. So there are many indications other than the BMI, and of course the main the guidelines are based on BMI, but we as clinicians should not base our views on the BMI. The central the waist circumferences, central obesity, and the metabolic profile of the patient is important. Then only we can subject the patient to bariatric surgery. Right.
So Dr. Pankaj says, are there any side effects of the herbal green teas that are taken for obesity? Also, does the tea bag or any link to any sort of cancer because of the particulate matter?
Actually, I don't know this for sure. There's a lot of good and bad things on the internet. So I cannot say for sure whether it is related to cancer or not. But yes, we do read such things on the net. But I do not know if there is a proper, what we call as a evidence based. Whether this sentence is evidence based. For that, we need a proper study, which it has been studied in many patients or many people. Then only we can say for sure. So there is no evidence as such.
Dr. Swami says, ma'am, few times heavy questions has been made.
I can't hear you.
A few times heavy flatulence has been misunderstood as obesity. Your comment on that?
No, actually, see, flatulence, the patient will experience the decrease in the obesity or the increase. We're talking about central obesity here, right? So that person will have more symptoms of indigestion other than just flatulence. So it can be, just be irritable bowel syndrome or irritable bowel disease or something else in addition to the flatulence. So the chances of it being misunderstood as obesity are less, but then IBS can be a part of obesity. What will help you here is again a UHG or a body composition.
Next, Dr. Pradeep says, what about the sarcopenia incidence after bariatric surgery?
So there have been many articles about the malabsorptive procedures giving rise to sarcopenia, and there have been many studies. So because these are evidence-based sentences, we have to be on the lookout and we have to be alert and we have to prevent this by looking after the protein and the activity of the patients and preventing sarcopenia. If we find too much of malabsorption, if the patient is losing too much of weight, there have been incidences where surgeons have reversed the procedures. So I have seen one to two patients who have lost too much of weight, unable to maintain themselves, especially middle-aged females who was illiterate and she just couldn't manage herself. So in such cases, yes, but it is known, but it is only if we do not pay attention. Yes.
So, doctors, in the interest of time, taking the last two questions for tonight. So, next is from Dr. Rao. Does liposuction have a role in the management of antiretroviral drug-induced lipodystrophy, especially the buffalo hump in patients who are on statins?
Actually, I'm not the right type of a person because liposuction is done by the plastic surgeons. So even the liposuction is done in our center, it is done by the another visiting surgeon. But I think so. It can help if logically, if you think if it is only a pocket of fat, it will help. But this is drug induced. So I don't know how long it will say. It is not something which, liposuction is not a permanent procedure. So I wouldn't be the right person to answer this.
So, taking the last question from Dr. Krishna Priya, ma'am, would you recommend any oral B12 preparations and the dose, please?
So actually, we use for our patients various bariatric formulations, and the these these are the recommended doses which are mentioned in the ASMBS guidelines. So there is not just one any, I don't know whether I'm allowed to take any market names or not, but there are some combinations where you have B12 with folic acid, and so we try to use that. Or then we have various multi vitamins. We have something for the hair, but that also contains B12. So yes, there are many preparations which are available.
So, ma'am, that is it for the questions. Thank you so much for patiently answering all the questions from our doctors. And with this, I would also like to mention that there's a lot of positive feedback for the session from our doctors. It seems that it was really helpful for our doctors. And thank you once again for this wonderful session. It was lovely to have you back on Medflix. Really hoping to see more of you on Medflix, ma'am. Thank you once again for the session.
Thank you very much.